guys ready to get started? Always ready?
Always ready.
That's the answer, right? All right, so yesterday, first of all, I really hate virtual lectures for ortho. It's really a tough course to teach virtually because there's so much physical exam stuff. There's so much stuff that I want to demonstrate to you guys, and or go through some anatomy review stuff that I can point out a little bit better. And then, if you guys are shy about asking questions, which you are, you're even more shy about asking questions virtually, right? So, but I do appreciate when you guys ask questions, because then I'm like, wait, did they get it? Did I teach it good? So continue to have that mindset, okay? Any issues before we get started today? Everybody loves farm, right? Yeah. About that. So talking about the stuff from yesterday, just real quick, not necessarily a review per se, but just getting to some points where I'm like, okay, what was some of the things I would like to have commented on? If you look on this slide here, you can see the ligaments that are on this slide here, correct? Under description?
Sir.
Okay, so that's, again, CC is corticoclavicular, so CC right here in this description column is corticoclavicular, and AC is acromioclavicular, correct?
Yes.
And that's those ligaments we're talking about, okay? The distance thing, I thought I did a decent job of giving you guys a picture that kind of shows that, okay? So that's that corticoclavicular distance, okay? So that's the distance between the coracoid and the undersurface of the clavicle. Make sense? So when you go back to this classification system, that's how you should think about these things. All right? Now again, I'm not trying to be too nitpicky about these classification systems. Excuse me, I'm still trying to get my voice back. Classification system, but because this is not orthopedic surgery, right? This is not an ortho surgery class. I don't need you guys to classify and tell me what surgery to do. But it's just important to understand that when you start getting into the type 3, right, controversial, correct? Then we start talking about surgery, okay? So why do I highlight that? I don't know what that was. Why do I highlight that? Because 1 and 2 is you, 3 or more is ortho, okay? 1 and 2 is you, 3 or more is ortho. Make sense? Okay, so if you think about it in those terms, when you're reading the scenarios that you may see soon, and it's asking you a treatment decision, that's how you're going to decide. Is that a good way of explaining it for you guys? So 1 or 2 is you, which means you send them to physical therapy. 3 or more is ortho. Can you send a 3 to physical therapy and to ortho?
Yes.
Yeah, you can. Okay, would I get that tricky on a question? You want 53 questions? Fine, we're already up to 52, right? So I wouldn't, but I'm just saying, just think about this, because again, I'm not just trying to teach you how to pass tests, I'm trying to teach you how to think in clinical situations. That way when you guys are out there in a year and a half, and you're like, oh my God, I thought I was going to know everything in the world by the time I graduated PA school with rotations, right? You can hopefully think back to what I'm telling you. Make sense? Okay? All right. Other questions? Piano key sign, that's a thing. Okay, so piano key sign there, as you can see, it looks like a piano key that's elevated, right? So it means you haven't depressed the piano key. Okay, so when you talk about a piano key, can you depress a piano key?
Yes.
You can. You can push down on it, right? So a key sign is the appearance that you see there. A key test is when you take your hand, put it on the distal clavicle, push down, thank you for demonstrating, and jelly's on it, right? You push down on it and you're able to depress that. Okay, so that's a piano key test. Make sense? So don't get the two confused. Good to go? Okay, anybody here play piano? No? Yeah, good. Piano's fun, I wish I kept up with it. These tests here, we'll go through it in the lab, okay? I don't want to get us behind. I don't really feel like I'm behind. I always feel like I'm behind because I want to teach you guys how to take this information and remember it, right? But we'll go through these exams. Number 1, cross-body test. It's also called the scarf test, right? Nobody calls it that. But if you have to remember it, right? It's like a scarf across your chest, okay? That's why it just sounds weird, right? And Jelly's laughing again. All right, so it just sounds weird. But cross-body test, cross-body adduction test, all those things are the same thing. AC shear test, that's shear. Everybody knows what it means to shear, right? Right? You're putting forces from anterior to posterior, and therefore back, so it's posterior to anterior, so you're shearing, okay? And you're trying to find instability there in that direction. You see the arrows right there? It shows you anterior, posterior there. Okay, so it's a back and forth motion, okay? That's different than the piano key test, right? Piano key test is superior to inferior. Make sense? Okay, so don't get those two confused, okay? And then active compression test, sorry.
I was just curious, for the AC shear test, would a positive for that be pain or would it be laxity?
It's never pain, right?
Okay.
Okay, that's a good question. He was saying it right. So what his question was, for an AC shear test, is pain a positive test? No, it's shearing. You're supposed to get motion there, right? So it's a test for instability. That's a really good question. Thank you for asking it. Okay. Active compression test, what do you guys know that as? O'Brien's, same thing. So does that mean that O'Brien's test is very non-specific and low sensitivity? Yes, it is. And we'll talk about that when we talk about biceps tendon pathology and when we talk about labral tears, okay? Good to go? So I provided those pictures there for you, but again, we'll go through that in lab, I promise you. I have been mounting a roster of instructors to be at the ready when you guys are practicing, okay? Good to go? Okay? Other stuff. Don't worry about the surgical stuff because this is not a surgery class. Oh, this slide here, everybody got a sense of what I was talking about yesterday? Okay, there are only two in your book that are covered. Okay, it's the traction, correct, and the compression force. Right, so that's A and C on there, on that picture that's on the left, okay? Now, the B is just a direct blow to the brachial plexus. Does that make sense? So if someone hits you with the crown of a helmet, right, a football helmet, okay, that could be a type B. But for the purposes of your book, they really only cover A and C there, which is the traction force and the compression force, okay? I do recommend this article that I took my time to make sure that if you click on it, it'll actually go somewhere. If it doesn't, sorry, just copy and paste, okay? I am working on Canvas, and Canvas these things, okay? Pre and post ganglionic, you better know that. You probably already know that, right? So pre-ganglionic, especially avulsion injuries, like the bottom one there, okay? Bad. Poor prognosis. Those are bad. Okay? Good to go? What else? Radiographic stuff. Frozen shoulder, you guys understand that frozen shoulder is active and passive range of motion, right? Not just active. If you have somebody that has pain and you ask them to elevate their arm above their head, are they going to do it on their own? Oftentimes, no. They'll do it going to a certain point, and then you'll have to grab their arm and gently continue the elevation, okay? Or the adduction, correct? Okay, forward flexion, adduction, okay? All right. Oh, my shoulder's hot. All right. Martha, okay? This one here, I tried, I don't know if you guys could see the marker, I was told you could, but basically, you should have an inferior pouch. If you go from left to right, you lose the definition of the inferior pouch. That's all that's showing you there, okay? These tests we'll go through again. Joe test, now that we were asked a good question, right? Joe test, is that a test for pain or weakness when it comes to impingement syndrome?
Weakness.
In that case, it's pain. Right? Okay, trick question. You see what I'm getting at? I'm trying to get you guys to think. Okay? When you do a Joe test and they have pain there but not weakness, your differential should include AC joint impingement. Could it be a rotator cuff there? It could be, right? We talked about partial thickness. versus full thickness. So read the scenario. I'm giving you a kind of an insight into what you may see soon, right? Read the scenario, read the exam findings, try to put it all together. Don't just be like, all these tests are for pain, or all these tests are for instability. Think, okay, good to go? Near test, is that an active or a passive test? Passive, for the love of God. If you tell a patient to do this, right, and their shoulder hurts, right, this is why I can't do a virtual lecture, because you guys can't laugh at me. Right? I like when you guys laugh. So, because then you remember it, right? So if you ask a patient to do this, and their shoulder hurts, they won't do it. So you don't have to do it, okay? Good to go? Hawkins-Kennedy test, there is a Hawkins, and there is a Kennedy test. Well, guess what? We put those two together and call it a Hawkins-Kennedy test. We'll go through that in lab again. Is that an active or a passive test? Passive, for sure. You ask somebody to do this, they're going to look at you like, what is happening? Right? They're not going to do it right, basically. Okay? This one here, I'm not going to give you a radiograph and tell me what type is this acromion. Just understand the pathology is preceded by abnormalities of the acromion. Okay? If you understand that, what's that called? Down sloping acromion. Okay? So if you see it on a radiograph report in the future, then you won't make that mistake. You'll be like, oh, there's a precursor here for impeachment. Okay? Steroid injections, no greater than 3. Perfect. Okay. No greater. I mean, it's on 2 freaking slides, right? So, like, it's important. Failure of how many months of physical therapy? 3. So, again, ortho is very simple. 4, 6, 12, right? 3. Right? Our numbers are very consistent. So you guys are going to start noticing those patterns. Okay? That's it. Rotator cuff tears. Somebody asked a really good question yesterday. Can you get partial thickness tears more so in more active populations, i.e. military? Yes. But the incidence of traumatic ruptures is still low. Unless there's a history of trauma. Okay? It's after lunch. We'll see where we get to. Okay? Make sense? Other questions other than what I just reviewed? Nothing? Okay. New business. So now we're going to continue with shoulder pathology. We're going to talk about rupture of the proximal biceps tendon. So we already discussed in our anatomy/MSK imaging review that the biceps brachii, right, that denotes it's plural, correct? Biceps brachii, right? So that means there's a long head and a short head of the biceps. When you're talking about a rupture of the proximal biceps tendon, which one are you talking about? The long head. Don't get that confused. Shoulder instability, whew, I could lecture on that for a year and still not get to the point where you guys understand that well. Okay, shoulder instability is tricky. Slap lesions, thoracic outlet syndrome. What do people confuse thoracic outlet syndrome with? Brachial plexus injuries. Right, so they're spaced out for that reason. Okay, they're spaced out. Separate them. Remember how I told you guys when you look at those reading sheets, they're not homework. That tells you have to do them. But when you look there and you start laying them on top of each other and see how they're different, you should know that, okay? Neonatal brachial plexus palsy and torticollis. Those last two are pediatric, okay? Proximal biceps tendon rupture, we just discussed, long head of the biceps. So this is a concept I'm going to introduce, and then we'll talk about in the next slide too. When you look at the glenoid fossa, right? The glenoid fossa, which is the cup that the ball goes into, right? That's the head of the humerus. So the glenoid fossa, you should look, when you look at it, you should think of it like a clock face, okay? So at the 12 o'clock position is where the long head of the biceps inserts into the glenoid fossa, okay? Right at the supraglenoid tubercles. So why is that important? Because is there a labrum that's also continuous all the way around the glenoid fossa? Yes. So if you have somebody that has pathology with the long hair of the biceps and or the labrum, the clinical picture can be a little mixed, okay? But this is talking about a rupture, okay? Proximal biceps tendon rupture. So the distal we'll talk about later, okay? Usually occurs with in patients that are older. Oh, look at me. Okay. Older, yes. All right, so I'm actually in the right age group. So, but they also have a predisposition to rotator cuff pathology. Okay. So you can either have inflammation, or you can have a tear, or you can have, what does the slide say there? A rupture. Okay, that's a continuum. Make sense? A lot of times people that have proximal bicep tendon ruptures have pre-existing tears or a history of shoulder pain. Okay. So is it common or uncommon in young adults? Uncommon, right? So I want you guys to key in on that. Okay, so read your scenarios, read your vignettes. Okay, what is also uncommon in young adults that we talked about? Rotator cuff tears, right? So start thinking about these things in categories. Right? Look at the vignette. You're like, it's more than likely this, or it's more commonly found in this age group, etc. Okay. So, but what are the exceptions? Weightlifters, okay, and throwing sports. Also, some degree of special activity groups. Okay. So, does anybody know what the Iron Cross challenge is? That's where you take two really heavy dumbbells, right? And you fold them out like this. Okay, does that put a strain on your biceps? All right, so we got people that have injuries when they're doing stuff like that, like certain gym activities. Okay, that's why they call weightlifters is on there. Okay, but you can either have proximal or distal. We'll talk about that a little bit later. Are they common or uncommon in young people, though?
Uncommon.
Okay, good. I think we made that point. So here's that clock face. I added this slide. So if you look at it there, you see the 12 o'clock position here. Okay, right there and right there. Okay, BT is biceps tendon. That's the long end of the biceps, correct? Okay, so again, that long end of the biceps is right there at the 12 o'clock position. Okay, so think of it like a clock face again. Okay, so clinical symptoms, a lot of times the patient will feel pain, sharp pain, and then an audible pop, right? Does anybody here have a proximal biceps tendon rupture? No? Okay, but people, somebody said yes? You have? Okay. Did you hear a pop? You did, right? It's like a weird concept. How can you hear that? Going back to this picture, is the long here, the biceps intra-articular? It is, right? It's in the joint, correct? The answer is yes. So how can you hear it if it's in the joint? Because that tendon is under such tension that the amount of force that it takes to, do you mind if I ask how you did it? During PT? You're getting after it? Weightlifting?
Yeah,
Weightlifting.
weightlifting.
Yeah. So he said that he felt the pop and then his arm went dead. He's exaggerating a little bit. We'll feel sorry for him a little bit. But he admits to the audible snap, right? So do you guys remember when I told you guys when you're getting an ortho history, ask them about the snap, crackle, pop? This is the snap. Make sense? Or the pop, right? What's the crackle? Arthritis. Everything hurts, okay? Right? Bulge in the lower arm. This is a concept we'll go through again, but let's talk about this. Which end of the long hair of the biceps pops? Proximal. Which end, therefore, is still attached? So if you flex an arm, do a flexion, right? Resisted flexion. Everybody sees what I'm doing? Right? Which end is attached again? Distal. So that bulge or that Popeye deformity will go distal. First introduction to your future. Understand what happens when you have a proximal biceps tendon rupture versus a distal biceps tendon rupture when you do a resisted flexion. Okay? Popeye deformity. Everybody knows who Popeye the Sailor is, right? Nobody was like raised on the moon. Okay? All right. Yes. If you were, that's fine. I won't judge you. But Popeye deformity is for that reason. Okay? It's a bulge distally, correct? So just for giggles, right? We haven't even talked about distal bicep ruptures, but what do you think that bulge is in a distal biceps tendon rupture? Reverse Popeyes. okay? Just to get the juices flowing, right? Get you guys thinking. But for Popeye, it is proximal biceps tendon because it looks like Popeye the Sailor. That's what you're going to see there, okay? That ecchymosis there is very dependent, okay? If it's early on, yes, you'll see that ecchymosis kind of down the medial aspect of the biceps and the lower arm, okay? So focus on the fact it says acutely. If it's not acute, the ecchymosis can be more dramatic and a little bit less specific, okay? But the things that are better in denoting these pathology is that you're going to see that bulge again distally, correct? And therefore, if the bulge is going distally, the defect is proximally. We have an intruder. Okay, she fled. All right. So the bulge goes distally, but the defect is proximally. Does everybody get that? Okay, yeah. I hope. Defect literally means where it popped. Okay, you can feel it. There's an abscess there, right? You see that divot there that's been formed, where that nice acute bruise is? When you feel there, you'll feel the divot or the defect. Defect is a better term, right? More specific, more ortho. Good to go? Okay. And they have tenderness at the bicipital groove. We talked about the bicipital groove when I talked about radiology stuff, right? Okay. If that pops there, that's where you're going to have pain. Again, that's getting back to where the pathology exists. So take those 4 factors there and put them together with the resisted bicep flexion. Okay? Yes, it worsens the deformity, but the deformity can also be worsened by a distal biceps rupture. The difference is where does the muscle group go? Right? The muscle's not torn, right? It says tendon up there, right? Okay? Make sense? I'll do a better job of explaining when we get to distal. All right, so imaging, is it important to get imaging? Do you get images on all patients that sustain shoulder injuries? Absolutely 100%. Okay? AP and axillary. Right? That can discern other issues. Okay, rule out fractures. But typically in this, is this soft tissue?
Yeah.
Yeah, so it would be normal, potentially, right? Okay? An MRI, it says order as soon as possible. Okay? I will teach you guys to think MRI first when it comes to these injuries, because we want to decide where the rupture is and where it lays once it ruptures. Remember I told you about that force that is that tension that's established there, right? And then once that tension is released, guess where the tendon goes? Wherever it wants to go, right? It's not under tension anymore. So especially if an injury is older, once that tendon pops and it's somewhere else, right? It's not at the 12 o'clock position, then they may start scarring down wherever it sits, wherever it decides to rest and settle, right? So we want to decide what the extent of the injury, okay? And to rule out rotator cuff pathology, okay? Why rotator cuff pathology? Go back to this slide. What coexists with it? Most common in older adults with rotator cuff disease. Those 2 points go together. You go with that? Okay. All right, so there it is. So they're making a muscle, right? You ask them to make a muscle. That distal aspect is still attached, therefore the deformity will be accentuated distally, correct? Okay, I put the red arrow there. So, but the big thing about this is that a lot of times, again, they happen in older adults. So if you understand that you only lose about 10% what? Elbow flexion and forearm supination. That's the 2 main actions of the biceps, right? Is flexion and forearm supination. So they're going to lose about 10%, right? But does that look cosmetically ugly to some people? It does, right? But I'll tell you right now, if I were to pop my bicep, my huge biceps, right? Right now, I would let it go. Because the risk of the surgery, you can still, and we'll talk about in a few slides, you can still have deformity. And you're only trying to gain about 10%, but you go through all the risks of the surgery, right? But just understand a lot of patients will come to you, especially if they're professional bodybuilders, right? And they'll say, oh, it just doesn't look right, doc. I gotta get this fixed, okay? Non-operative, minimal loss of function, acceptable deformity, okay, does the patient accept it? Right? You still put them in physical therapy, right? If they're non-operative, it doesn't mean you just don't do anything. And range of motion is important, correct? What's the enemy of orthopedics?
Stiffness.
Stiffness. We battle that every day. We're in the trenches in orthopedics, okay? Operative though, now say that they're young, athletic, right? Or young laborers, less than 40 years old, they got a lot to go, right? Say that they're younger people and they want to join the military and do certain things. They watch the All You Can Be commercial, right? And you know, all those exciting commercials that tell you want to go do this, right? So maybe they want that 10%, or maybe they just want to be whole, okay? Then that's something that we will consider operating a patient surgery. What's that number? 40 years old. Did you see 40 before? You think that is. What's the? This is a good point. You see, this guy thinks. Okay. I don't know what you guys think about it, but I'm saying he thinks, because what is the average age of a running back in the NFL? Not 40, right? Is Tom Brady an anomaly? Absolutely 100%. So I'm a big sports medicine guy. If you're 29 years old and you're a running back, you're an old dude. Correct? You're an old dude. Adrian Peterson notwithstanding. Adrian Peterson? Frank Gore, okay? 40 is old when it comes to ortho, okay? Makes sense? Maybe not chronologically, but when it comes to MSK stuff, we think differently. Yes, I know we think differently. We think about that in different terms, but 40 is old, okay? All right, so but you saw 40 before, right? Rotator cuff injuries. All right, again, ortho, we trying to keep it simple, okay? Okay, so just understand that. Don't get that confused. So therefore, the biceps tendon pops, right? Correct? It pops from that 12 o'clock position. We're going to go dig into the shoulder and reattach it where it came from. No, but we are going to do a procedure called a biceps tenodesis, which is where we're going to find out where it is, and we're going to tack it back down on the proximal humerus. That's all you need to know. Okay? Is it at the 12 o'clock position? This is the 12 o'clock position here, correct? Right? So that is not the 12 o'clock. This is the 12 o'clock. This is not, correct? So we will tack it down. Well, what we do, right? So think about this. It's this long to get all the way up and around and insert at 12 o'clock. If we're going to tack it somewhere that's shorter, are we going to have to shorten it? Yeah. Yes. That's what a biceps tenodesis is. You shorten the tendon to establish the tension and put it somewhere else. Make sense? Okay. And then usually when it pops, it's also kind of like stringy. Remember we talked about the word praying? Okay, so it's kind of stringy looking. So we take off about 2 centimeters. That's a lot. Think about it. Your fingernail of your small finger, not your pinky finger, guys. Your small finger is about 1 centimeter for most people. So 2 centimeters of tendon we whack. Okay? Yes, sir.
Is that just cosmetic, or is it restore the strength as well?
That's a good question. So again, they're going to lose 10% either way, right? So what we're trying to do though is establish that tension in a more distant location. So we're trying to basically recreate that tension so they don't have as much of a deformity, correct? So it really is for cosmetic purposes. Make sense? That's a really good question. Any questions about that? Okay, so adverse outcomes of treatment. There's that word stiffness, we hate it. Okay, surgical scar with little improvement. Sometimes you just can't get a good reestablishment of that tension, right? So we had a co-worker, she popped her biceps tendon. We told her everything, okay? And she's like, nope, I want to get the surgery, I want to look pretty, okay? So the thing is though, when we got in there, and I won't use names, but her biceps tendon was not the largest tendon I've ever seen. In fact, it's probably the smallest one I've ever seen. Right? So it was a challenge to try to reestablish that tension, and she still had a certain degree of deformity, but she was happier. So there you go. But she had the scar, she gave it that. Okay? Body, see how it says bodybuilders there? Okay. So what do you think a penis may look like? Right? You guys figuring this out? concomitant rotator cuff tears, you're always going to refer, correct? Young athletes, young laborers, we talked about that. And if you have somebody that's opted for non-surgical management, okay, but they go on to have persistent pain that's kind of out of the norm, order the MRI, refer them to us, because maybe they got something else going on. Okay, make sense? Any questions about that topic? We'll hit that again when we talk about distal biceps, because we need to get that in our head. You guys want to break down? Or push? Keep going. Okay, shoulder stability. So by definition, shoulder stability is something, again, it's in the name there, right? Instability. It doesn't say shoulder pain, it says instability. Okay, so this is when you're really going to start bearing down on your physical exam special test, and then the way you think about these things, the way you talk about them, okay? But by definition, they're recurrent episodes of subluxation and or dislocation. Let's get out of the way. I know you know what a subluxation is, right? It kind of comes out, but not all the way out. Maybe like a perching on the edge, but it doesn't come all the way out. A dislocation is it's out, right? And maybe somebody else has to put it in. When you ask a patient, have you ever had a shoulder dislocation? Because of course you will when you ask for history. And they say, I don't know, I don't remember. Trust me, they would remember, okay? Is it painful the first time? 100%, okay? So that's the difference. Maybe they had a subluxation, but they did not have a true dislocation. Good to go with the definition? Okay. Most common, foot stomp, hair on fire, spitting on the ground, breakdancing. Okay. Anterior. Anterior, 95%. When I say most common, I mean like super common. Like you shouldn't even think posterior, unless they have a history of electrocution or some kind of seizure activity or something like that, like it says there, right? Seizures and electric shock. Right? In that case, 80% are missed. And that doesn't mean it's more common. Right? It just means that they're missed because people don't consider, based on mechanism of injury, hey, this may be a posterior shoulder dislocation. Did I distinguish that okay? They think it's an anterior. Yeah. And so it's tricky. They try to do a reduction, they can't get it. Right? And it's like, well, yeah, duh, you're doing it wrong. Right? Okay? You're doing it wrong. So. Multi-directional, that's multi-directional instability. Okay, multi-directional instability. So remember I taught you guys about how some people are loosey-goosey with laxity in the shoulder joints? Out of character, right? Don't laugh again. Okay, so multi-directional is that hypermobility. Okay, terminology-wise, TUBS versus Ambry. TUBS tells you everything you need to know. You need to know these acronyms: traumatic, unilateral, Bankart, and surgical. It's in the name. Which one has surgery in the name? Stubbs. Is there an S in Ambry? Don't be that person. Okay? Please. Stubbs. Surgical. Okay? So Ambry is atraumatic, multi-directional, like we just discussed, right? That hypermobility. Bilateral, not unilateral, both shoulders, because they're loose in laxity. Right, in multiple joints often. Okay, what's the R stand for? Rehabilitate. Okay, it's highlighted. So that tells you that if a question asks you, what's the first line treatment for Ambry, what's the answer?
Not surgical.
Not surgery, correct? I like the way you guys think. And then inferior capsule, what does that mean? Remember we talked about the inferior capsule is where they have fibrosis and adhesive capsulitis. So in this case, a lot of times they have inferior instability. It's multi-directional, correct? So that means up, down, back, forwards, correct? All directions. So inferior instability, you guys already learned about the sulcus test. Sulcus sign. Okay, pull the arm down, correct? So they're going to have inferior instability oftentimes in Ambry. Okay, good to go? Are we okay with these definitions for now? Okay. All right, good. So anterior, again, initial trauma from a fall or a throwing motion, you know, especially if it's not their first time dislocating, right? So what is it describing there? Sensation that the shoulder's out of the joint with abduction and external rotation. Am I doing that right now? Yes. Okay, so throwing motion, basically one way to dislocate, correct? Is there a test for that that's called apprehension test?
Yes.
Yes, this is the test. So this tells you if it's anterior dislocation and someone says, well, what's the mechanism? Look on the answer choices on pants. The one that describes it like this, like what I'm demonstrating right now, that's the answer choice, correct? Keep it simple. Okay. Multi-directional instability, subluxation, or recurrent dislocations. So these guys are so loose that they can voluntarily dislocate themselves sometimes. Okay? Right? We're also loosey-goosey, right? So they're hyper-flexible. A lot of times they can take their thumb and touch their forearm with their thumb. That's just weird, right? When they can bend over and touch the floor without bending their knees, with both palms on the floor. I couldn't do that on my best day. Not even come close, right? Right? So they can bend their knees way back. You know these people. Yeah, right? So there's a movie describing an alien like that, but I won't get into that. Okay? But just understand multi-directional, if you get a scenario on pants very soon, and it tells you that they have instability in multiple planes, which one is it again? Is it Tubbs or Embry? Okay, perfect. Horse is dead. All right, so I added these pictures, okay? I don't know how helpful these are, but hopefully it accentuates the fact that you need to look at the patient too and understand what you're seeing. Okay, because the big thing about this is on physical exam, the arm should be held in a neutral position. Does it look like in both cases the arm is being held in a neutral position? Yeah. It does. So that's not necessarily the thing, okay? What you're going to do though is after you look at their shoulder, if there's an anterior dislocation, where's the head of the humerus? Forward. Forward. Okay, so if you look at this picture here, please use the word anterior. You're gonna make me sad. So you can see a bulge right there, right? And you can see a bulge right there, right? That's the head of the humerus. If you go down to this picture, is there a depression there?
Yes.
And a depression there? Therefore, the head of the humerus is not anterior, correct? So where the heck is it? It's posterior, because that's a posterior dislocation. Make sense? So you can get a lot from the physical exam too. Good to go? So with anterior, the nerve that you need to know about is the axillary nerve. How do you get somebody to check axillary nerve? Like, do you need to have them go all the way up here like this? No, you literally walk up to them and you say, push on my hand. There you go. See, that's all she did. Axillary nerve is intact. So all she did was go like this a little bit. So you can literally have her arm to the side and just say, push on my hand. Make sense? Is that the axillary nerve? The answer is yes. Okay, so but you're going to check that before and after. If you do a reduction and it was in before the reduction, you check it afterwards and it's out, get some x-rays. You may have missed something. You may have missed something worse. Okay? Posterior is the adduction in internally rotated position. I know it's really hard to see in this picture, but basically internal rotation, you would agree, is like this, right? When they're rotating, so the thumb, if you look at your thumb and you're looking up at 12 o'clock, their thumb has not gone down to what position? 6 o'clock. So their arm is going to be down at the side like this, still potentially, but their arm is rotated inward. We go with that? Okay, I like to use the thumb because everybody knows if you take your thumb like this, put it straight up to the sky, again, rotate it down to the 6 o'clock position, you are in internal rotation, correct? So that's what you're going to see. Not only is their arm held close to their body, but it's internally rotated. Good to go? Okay, you good with that? I hate virtual lectures. Okay, so we're going to talk about these again, but instability, especially chronic, right? The posterior sulcus sign, that's for that hypermobility normally, correct? Does that really have any play in anterior dislocations? Not necessarily. Okay? So apprehension test, again, anterior, right? Jerk test, not the patient is a jerk, but a jerk test, right? Also, there's a clunk test. What's the difference? We'll get into that in lab. Let's not get on that today. Okay, but jerk test is for posterior, correct? Because in a jerk test, right? I'm getting hungry. I'm thinking about beef jerky. In a jerk test, you're pushing the head of the humerus back, correct? So that's posterior. Make sense? She's laughing. Okay. So imaging wise, I'll finish this up on this slide, we'll take a break. So imaging wise, you want to get a AP and axillary view. Hopefully this horse is so beaten that you guys get the right answer, but what's the view you can get even if they can't take their arm and put it into the axillary position? Scapular wide, right? Because you guys are already experts at deciding which one is anterior and which one's posterior based on the acromion and the coracoid, correct? Of course you are. Okay? So post-reduction radiographs, so the head of the humerus normally goes anterior, correct? So the head of the humerus goes anterior. Which aspect of the humerus is resting on the glandular now? Let's think about this. Should start like a timer, right? The posterior. So that's what a Hill-Sachs lesion is, right? So you see that ding right here on the posterior, right there, and a ding on the posterior? That's a Hill-Sachs. And that's why it happens, is since the head of the humerus goes anterior, right, the posterior aspect of the humerus is now resting on the glandular rim. So that's where the divot is. Make sense? And it's traumatic, correct? So it dings the bone, okay? So a Bankart lesion, right, so when you go anterior, not only does it head go out, but it also shears a certain portion of the labrum sometimes, especially in the inferior aspect. So a Bankart lesion is that bony defect at the anterior glenoid rim. See where the black arrow is right there? See where the black arrow is right there? Okay, so that's a Bankart lesion. So those are the two things you can see. Okay? Is it more appropriate to call a Bankart an anterior-inferior lesion? It is. Okay, but your book just says anterior. But it's on the front, correct?
Yeah.
So you guys remember how we talked about a true AP view of the shoulder versus an AP view of the shoulder? So do you think that maybe one view is better at seeing Bankart lesions if there's a question of whether there is? Yes, so that may be an example that I'll give you guys where maybe you'll order both of those tests. Okay? Both of those views. In arthrogram, so is it in arthrogram the best thing for looking for a labral tear?
Yeah.
Yes. It's in yellow. Okay? So I will tell you this, you're digging bone, right? Both on the anterior aspect of the glenoid rim and on the posterior aspect of the humeral head, but are you shearing that labrum as well? Yes. Okay, so that's why you get an MRI. Okay, axillary nerve injury should always be considered and concerning. Okay, if you find evidence of that. Okay, recurrent instability, and we have a saying in orthopedics: everybody gets one. There are people that debate that, but everybody gets one dislocation. Once they have two, surgery for everybody. Okay, if they're under 25, this is FYI. But I'm just telling you, if they're under 25, sometimes we'll offer them surgery because they got a long way to go, correct? Okay. Glenohumeral OA, remember that goat spear that I talked to you guys about? Okay, so if you see a goat spear on a radiograph, that's OA, right? That's osteoarthritis of the glenohumeral joint. Treatment, reductions, obviously, okay? Do you need sedation? Yes, especially if it's been out for a long period of time, okay? Now, the techniques for reductions, I'm not going to discuss those in detail. There's some examples there. There are ways that I do it. I never miss. It's not possible, okay? So sometimes you have to switch things up. So you also have to switch it up depending on how long it's been out. Do you think there's more or less muscle tension when the dislocation has been present for longer? More. So therefore, yeah, we got drugs, right? Relaxants, right? Pain drugs, all that stuff. But depending on how long it's been out, maybe you have to switch up the script. Flip the script, as my kids say. Right? So sling for 3 weeks and conservative care, correct? Yeah. Your book says 3 weeks. What's testable? 3 weeks. What do I tell my patients? 2 weeks. What's the enemy of orthopedics? Right? So the least amount of time is possible, but they're at the greatest risk for redislocation within that first 2 weeks. Okay? Your book says how many weeks? 3. Perfect. Ambry, do I even have to go there? It's the R, right? Rehabilitation. Okay. Treatment, surgery stuff, tubs, right? Surgical. So labor repair is what that picture shows you there. red flags. You try to put it back in, you can't. So what do you think happens? Like you said earlier, they think it's an anterior, right? They can't get it back in. They're like, what the hell's going on? Is that an irreducible dislocation? Yes. So then you call me. Okay? I applaud family practice guys to try to put them in. 1, maybe 2 tries. Call somebody. Can you cause humerus fractures?
Yes.
Trying to be too aggressive? 100%. Okay? Multi-directional instability. Somebody comes to see me with multi-directional instability. Is there a great surgery for that? No. That's why it's not in the ambry. Okay? So they come to see me and they say I have shown no improvement. I say that's good to hear that. Go back to physical therapy. They come back in 3 more months and say, I still haven't got any improvement. It's like, oh, that's nice. How's your mom doing? Go back to physical therapy, right? So we try to delay surgery because what are people that are loosey-goosey tend to do after you do a surgery to make them not as loose? Get loose, right? They get loose again. Like that's just their genes. That's their genetics. So even if you tighten them up, they can loosen again, right? Make sense? So there's no great solution for that. PT. Let's take a break. You want a little bit longer break? You guys are talking about pathology stuff and making fun of people. I love it. What's that? Over the break? Okay. All right, she's shy. All right, so slap lesions. Okay, so the term lesions is something your book uses. It's not wrong, right? But when you think of slap lesions, that's AKA slap tears. Okay, guys? Good to go. All right, so superior labrum, anterior to posterior tear. SLAP. So, that's superior, correct? Does that involve the 12 o'clock position? Yes. Okay, so think about that, okay? You're gonna sleep, go outside, please. So, superior glenoid labrum. So what's that 12 o'clock position commonly called? Long head of the biceps anchor, okay? Why is it called an anchor? Because that's where the long head of the bicep is anchored into the labrum, correct? Okay, so those things are synonymous, okay? Make sense? So if you hear the terminology long head biceps anchor, what position of the labrum are you in?
12 o'clock.
12 o'clock, correct. Okay. So if you have a slap tear though, that's labrum, correct? Is labrum tissue like the menisci tissue? Yes. Okay, so the 2 most common lesions, to use that terminology, are fraying and or frank tears. Not frank as in the man, right? Frank meaning as in obvious and apparent. Okay, makes sense? So fraying is just like it sounds, it's like horsehair. Okay, kind of chopped meat. We call it crab meat. Does everybody know what crab meat looks like? Right, it's kind of frayed looking. I kind of getting hungry again. So fraying usually is degenerative. Okay, so when you think about fraying, you think of degenerative. So over time, correct? Okay, old man time. So, and then frank tears tend to be what? Acute or chronic. Okay. What's the difference between chronic and degenerative? Sometimes they're the same thing, correct?
Yes.
Okay? So don't get too bogged down on that. The big thing is it a big tear or a small fraying? That's it. Okay? So does everybody see this structure right here? What is this structure called? Transverse ligament. Okay. Yes, that is what it's called, correct? Okay. Somebody's Googling it right now. Okay, good. So what restrains the biceps tendon and the biceps groove? That ligament, correct? Okay. So again, if you have a tear in there and you get an MRI, could you also have slap lesions and also, biceps pathology? Yes. Don't get too bogged down on that. Focus on your special tests, okay guys? Clinical symptoms, often a diagnosis of exclusion. Why? We talked about this before, is the labrum intra-articular? It is, correct? Correct. So since the labrum is intra-articular, it's deep, isn't it? Yes. Deep, okay? So again, sometimes they'll just say it hurts where? Right about here, right? They'll literally go here. They'll just go like this. It's like a big area, correct? Whenever possible, you can ask them with one finger, correct? But they still might do Well, I can't really do one finger, it's kind of here. Okay, so then what's going to help you? You're going to exclude things based on your physical exam, correct? Of course you are. Mechanical shoulder symptoms, here comes that snack cracker pop again, correct? So doesn't the labrum provide more surface for articulation and also stability? It does, right? So if you have popping and clinking, could that be an indication that there's instability in the anterior direction based on the labral tear? The answer is yes. She agrees with me. So, but here's a term that really people tend to say, well, if it's pain with overhead activity, it's only this. Nope, you're going to see that in multiple slides. You already saw it yesterday, didn't you? Okay, so pain with overhead activity is not necessarily one thing. Okay, often described as what? It's interarticular, correct? So as a deep, deep, deep pain inside the shoulder. Good to go? Special tests, right? Cleaned up that slide pretty good, I think. So I kind of highlighted those special tests for you there. Okay? If you go on Google and you look for that image that corresponds with that, with what's up on the screen, excuse me, it's a video. Okay? It's a video you can watch. But we're going to go through that as well in the lab. So no worries. Okay? O'Brien test, that's also called active compression test, correct? But in this case, you're using it to try to decide if there is a slap lesion. Crank test, blunt test again. Resisted, supination, external rotation. What is supination? So is that palm up or palm down? Palm up. And what is external rotation? What I'm doing right now? Yes. Okay. So just think about it. Supination, external rotation. So is that an active test or a passive test? Active, correct? Make sense? Okay, trying to highlight some differences for you guys, okay? Speeds test, arms straight out, correct? You would agree that with the O'Briens, right? You're going thumbs down, correct? You're coming in about 10, 15 degrees. This is the position for the O'Briens. Does anybody disagree with me? Okay? What is the position for that you're going to test with first? Thumb down, correct? Then you're going to ask them to go thumb up and test them again, right? Now with the speeds test, it's only one position. It's palm up, like you're trying to get changed to the Burger King drive-thru, right? And you want to change, right? And then they're resisting. Where's the pain in the speeds test? Is it the bicipital groove? Yes, that's the kind of pain you're looking for, correct? Now, if they say they have pain somewhere else, like the posterior shoulder, is that positive for biceps versus slap lesion pathology? No, that could be an indication of something else. Make sense? So you ask them not only to do the test, but where's the pain? Make sense? Okay? Good to go? Okay. Force sensitivity specificity, and it's supposed to elicit pain as the lesion is compressed. Okay? So it's called active compression, correct? So compression is the key here. If you're doing an O'Brien's, do you think it's really important? Remember I used the analogy of a thumb, correct? When you use your thumb like this, right, you hold your arm out like this, you go thumb to 12 o'clock, is that enough? No, sometimes I tell them, really get that compression in there. It's kind of equivocal, right? Everybody knows what the word equivocal means? Not sure? Okay. Plus or minus? Okay. Really get that compression. It's called maximal internal rotation. Make sense? Okay. We do say thumbs down, don't get me wrong. But if you come, if I happen to be your preceptor next year because I got fired, and you come to my clinic, I'm going to I'd expect you to do maximum active compression. Make sense? And so that's maximum internal rotation. Okay? Good to go? Slap lesions, imaging. So do you think that we get a lot of MRIs if we suspect slap lesions? A lot, right? Like tons. Do we get x-rays first? Absolutely 100%. Rule out other pathology, but don't be surprised if they're normal, correct? What's the gold standard, people? Arthrogram, correct? Okay, some of you guys have been out there, super medics, et cetera, right? And you know, like, well, my doc never orders arthrograms because the technology of MRIs has improved so drastically. We've gone from a 2T MRI to a 4T. Congratulations, you know that. Great. Order an MRI arthrogram until you get out of practice. Okay? Because that's the gold standard, correct? Why is the MRI arthrogram the gold standard? Because you can get better definition of the labrum itself. Okay, good to go? Perfecto. MRI without contrast has sensitivity less than 50% people. Okay? What's that circle showing us? Do you think I'm showing you a labral tear? Yeah. Does everybody see it? No. Does anybody see it? Right? It's there, I promise. Again, it's very subtle, right? Something you're going to have to look at a lot of MRIs. I would never ask you that question. But when I ask you what the most sensitive and specific test is, what the gold standard is?
MRI.
Okay, good. Thank you for answering. So outcomes of disease, obviously, if you don't do something about it, they're going to, adverse outcomes, they're going to have chronic pain, right? Some disability with activities possible. So they're still able to do things, right? But they'll tell you when they're in certain positions, not just overhead, but certain overhead, like my arm is a little bit out like this. Usually it's more that it's midline, right? Is that causing compression, guys? It is, right? So that's what they're doing. They're actively compressing themselves. Not maximally, because then you have to do this to do maximal, right? But they're causing a little bit more compression there. But they're still able to do activities. Right? So slap tears, slap lesions, depending on the extent of it, conservative care is usually indicated for most slap lesions, okay? Especially if they're small and if they're fresh, per se. So physical therapy is in yellow, right? The big thing about this is people say activity modification. Well, guess what? If it's something that puts active compression, which activities do you think you're going to have to restrict them from? The ones that cause active compression, correct? Overhead activities, heavy dumbbell lifts, right? Bicep curls, things like that, right? So the long head of the biceps, we just talked about this earlier. Okay, it goes up, across, through the bicipital groove, underneath the transverse ligament, and inserts at the 12 o'clock position in the glenoid fossa, correct? So, therefore, if you do a biceps curl, do you think that puts tension across the shoulder joint? Yes. Okay, so they can have a little bit more pain with bicep curls. So restrict that too. Okay? Limit throwing. If they're throwing athletes, limit the throwing for at least 6 weeks. The reality of it is, usually with slap lesions, okay, you're going to have to limit it for a significant amount of time. Okay? So that's going to be challenging. Right? But just remember, if it's a scenario that's given to you, right, that says if the patient has throwing activities in their life, then you want to look for the non-operative indications, right? And they're there. And they'll come up on the next slide as well. Now, operative is reserved for non-operative treatment failure. Okay, if somebody comes in, let's think about this for a second. So if somebody comes in, they have a labral tear or a labral lesion, right? Slap lesion. Okay, specifically slap lesion. Superior labrum, anterior, posterior. Do you think that they're going to possibly have a little bit of restricted range of motion, at least actively, secondary to pain, not weakness?
Yes.
Yes. So depending on how much restriction of motion they have, we say go to non-operative treatment, come back, we'll offer you surgery then. Why? What's the enemy of orthopedics? Stiffness, right? So if they have stiffness preoperatively, do you think that's a predictor of having more significant stiffness postoperatively?
Yes.
It is. The answer is yes. Okay, so again, physical therapy is very important for this. Okay? Are slap lesions life or death? Okay, so think in those terms, okay? And if they're high-level athletes, so again, Adrian Peterson, I think Tom Brady had a slap lesion. Athletes, we may offer them surgery sooner, right? What's their money maker?
Arm.
Not their personalities, right? It's their arm, right? Their ability to throw, correct? So what's the surgery for it? Arthroscopy, comma, labral repair, right? Plus or minus biceps tenodesis. There it is. Why is the biceps tenodesis in there? If you have a labral tear, I don't know what that word is. If you have a labral tear in the 12 o'clock position, and you have biceps pathology too, do you think if you just treat one, that they're going to get 100% relief of their symptoms?
No.
Not usually. Okay? Makes sense? So you have biceps tenodesis, if you don't mind me asking, Robin, did they offer you any kind of labral stuff? You guys don't remember anything.
They drugged him up. He was feeling good.
But a lot of times, he's saying yes. So a lot of times, you know, they'll go in there and they'll take a look though, right? So just because they're going in there to tack that bicep down, doesn't mean they won't look for other things. If there's a labral tear, you see that probe right there, right? That's a probe. So it's basically lifting. This is the tear, right? It should be down like it is on this side. You see on this side how it's down, and out here they can lift it, right? So again, on this side for you guys, this is down here, and overhead they're able to lift it off of the rim there, right? So that's a tear, right? So how do they fix that? They literally use fancy sutures, essentially, and anchor it down, okay? So that's what's showing you on the right-hand side there. That's actually a very pretty looking configuration there, okay?